Good afternoon, ladies and gentlemen. Thank you so much for your kind introduction, sir. First of all, I would like to thank Ceylon College of Physicians for giving me this wonderful opportunity. So the topic I chose for today is direct oral anticoagulants and a practical approach to starting a drug on the patient. So today, in next 25 minutes, I'll be talking regarding a brief introduction, indication for drugs, and how do we start a patient on a drug, drugs-related bleeding, and anticoagulating a patient with a stroke. So what is an anticoagulant? It is an agent that inhibits one or more steps in the coagulation cascade. So depending on the route of administration, there are mainly two classes, parenteral and oral. Oral, we have the indirect anticoagulant, vitamin K antagonist, our good old warfarin, and we have direct oral anticoagulants. And there have been a lot of trials going on to identify more targeted oral anticoagulants. As a result, the factor 11 inhibitors are already in phase 3 clinical trials as third generation oral anticoagulants. So what are these direct oral anticoagulants, DOACs or NOACs? NOACs stands for the non-vitamin K oral anticoagulants. Depending on the target, they act on the coagulation cascade. We have two classes. One is a thrombin inhibitor, dabigatran. There's another set of drugs which act on activated factor 10. Those are evorpacept, edoxaban, apixaban, and we had betrixaban also earlier. Now it's no more there in the market. And moving on to pharmacokinetics and dynamics, overall, all four drugs has fairly short T-half, basically ranging from 8 to 12 hours, and they reach to maximum peak of plasma level within about 2 to 4 hours. So these pharmacokinetic profile makes it more advantageous when compared it with warfarin. So they have very rapid onset of action. So we don't have to bridge. And they have rapid offset as well. So in the case of surgery and in the case of bleeding, we don't routinely have to use any reversal agent. And their anticoagulant effect is fairly predictable. So there's no need of routine monitoring, and we can use a fixed dose. And compared to warfarin, they have very low potential for food and drug interactions. Okay, so how do we start a patient on drug? So once we identify that particular patient has an indication for anticoagulation, we have to see that particular clinical indication is a scenario where we can use a drug. So that depends on current evidence and patient's profile. So in current medical practice, there are basically three main clinical indications to use drug, which is backed by very strong recommendations and trial evidence. Those are the prevention of stroke in atrial fibrillation, treatment and prevention of recurrent venous thromboembolism, and prevention of major cardiovascular events in patients with coronary artery disease and the peripheral arterial disease. Nevertheless, there are still few scenarios where we can't use drugs. So in compared to warfarin, in these scenarios, drugs are not efficacious or safe. So in a setting where a patient has mechanical prosthetic valve, or atrial fibrillation with moderate to severe mitral stenosis, or VTE in antiphospholipid syndrome, we have to get stick our good old warfarin. And what about this thrombosis in unusual sites, like cerebral venous sinus thrombosis, big vein thrombosis, portal vein thrombosis, and catheter-associated VTE. So in these clinical scenarios, still the evidence and data is lacking. So we can't recommend drugs or warfarin. So in particularly with left ventricular thrombus and embolic stroke in undetermined sources. So for these scenarios, still we have to stick to warfarin. So I will rush you through a few case scenarios. So case one, Mr. A, an 8-year-old male, a diagnosed patient with atrial fibrillation, with background medical history of hypertension, diabetes, fatty liver, and previous ischemic stroke. He has had 2 recent falls, and his weight is 80 kilos, and creatinine clearance is 64 milliliters per minute, based on Cockcroft Gold formula. So how would you anticoagulate this patient? So thromboembolic risk assessed by CHA2DS2-VASc is 6. So definitely there is an indication for anticoagulation. So what is your choice of anticoagulant? Is it warfarin, drug, or heparin? Okay, so this is a scenario where we need to anticoagulate patient to prevent stroke and atrial fibrillation. So what are the indications for anticoagulation in A? So based on Chadwell score, we know if Chadwell score is 2 or more, it's a class 1 recommendation. Chadwell score 1 or more, we can consider anticoagulation, it's still class 2A recommendation. And irrespective of Chadwell score, if patient has any form of valvular heart disease, mechanical prosthetic cardiac valve, or bioprosthetic valve, or patient has undergone cardiac valvular repair, and in transcatheter aortic valve implantation, hypertrophic cardiomyopathy, and cardiac amyloidosis. So in these scenarios, irrespective of Chadwell score, we have to anticoagulate. Out of these indications, except moderate to severe MS, severe AS, moderate to severe MS, and severe AS, and mechanical prosthetic cardiac valve, and TAVI. In all other indications, drugs are actually preferred over warfarin for anticoagulation. So these recommendations are backed by very strong randomized controlled trials, the Cardinal 4 trials in AF and Engage AF, Aristotle, Rocket AF, and Rely, where they have found that drugs is non-inferior to warfarin, and actually it is safer compared to warfarin in terms of ICH. However, GI bleeding risk is more with drugs, except with apixaban. What about the patient's profile? What are the facts we have to take into account before we starting a drug for a patient? Basically, age and frailty, weight, patient renal and liver function, bleeding risk, and drug interactions, and pregnancy and lactation are contraindication for drugs. What about the age? Pediatric data is very limited, and we can start a drug in a full-grown adolescent, provided the weight is more than 50 kilos. And what about elderly, more than 75 years? So the main problems we come across is frailty, cognitive decline, fall risk, they are reduced creatinine clearance. But this frailty and fall risk itself should not be a reason to not to anticoagulate a patient. So what are the evidence we have regarding the safety and efficacy? All 4 cardinal trials included patients more than 75 in their patient cohorts. And what they have found, especially the Aristotle study, what they have found is all the patients with atrial fibrillation has more favorable outcome when patient is on oral anticoagulant rather than patient is anticoagulated with warfarin or not anticoagulated at all. Another observation they have made is the bleeding risk is less with apixaban and edoxaban compared to other 2 drugs. So what about patient's weight? Depending on the pharmacokinetics, pharmacodynamics, and the volume of distribution. So if we use a drug in a patient weighing less than 60 kilos and more than 120 kilos, we have to be very cautious. There are evidence emerging that rivaroxaban and apixaban can be used in the patient cohort with BMI between 40 to 50. But however, in these extremes of weight, we cannot use dabigatran or edoxaban. Renal function has to be assessed using the creatine clearance, but not with the usual CKD AP we use. That has to be assessed with Cockcroft-Gault formula. There, instead of ideal weight, you have to put the actual weight. That's how they determine the doses in all 4 phase 3 randomized control trials. And when it comes to the reduced renal function, we can't use any of the drugs if eGFR is less than 15 or patient is on hemodialysis. And when creatine clearance is less than 50, all 4 drugs has to be used in reduced doses. When we assess the liver function, you can see in a patient with chronic liver cell impairment, if patient is child A, we can use drug provided patient fulfills the other criteria. But in child B and child C, it's either caution or a contraindication. How do we assess a bleeding risk? Bleeding risk can be, for the drug also, we can use Hasbled score. But having a high Hasbled score is not a contraindication for anticoagulation. Why we are assessing this is so we can identify the risk factors and modify if there are any modifiable risk factors. And we can keep the patient under very close monitoring and follow-up. So this drug interactions, this is a well-known potential advantage of drug over warfarin. But nevertheless, there are few drugs which interact with drug, and we have to be very mindful in our day-to-day practice. I would like to mention very common ones. So the Antiepileptics such as phenytoin, phenobarbital, and carbamazepine, and especially antibiotics such as clarithromycin, azithromycin, mainly the ATT, rifaximin. Other ones are the antifungus, ketoconazole, fluconazole. So if we start the patient on these drugs, there are a lot of interactions, and they advise against using drugs if patient is on antifungal such as fluconazole or voriconazole. So according to all the facts we have discussed so far, how would you anticoagulate Mr. A? I would suggest we can anticoagulate him using a drug, and preferably apixaban or edoxaban. In Sri Lanka, currently we have only rivaroxaban and apixaban. So in that case, we can go for apixaban. The main concerns are his fall risk and liver function, the optimal blood pressure control, creatinine clearance, and the polypharmacy provided the background history patient is having. Okay, let's move to case 2. Mrs. D, a 44-year-old lady with history of hypertension and diabetes, was diagnosed with ovarian carcinoma, and she presented with left lower limb DVT. Her weight is 60 kilos and creatinine clearance is 70. So what is your choice? Warfarin, DOAC, or heparin? Basically, low molecular weight heparin. So treating VTE, mainly the DVT and the pulmonary embolism with DOAC. So there's good evidence, strong evidence to back this in treatment of initial and long-term treatment of VT for 6 months and beyond initial 6 months to prevent recurrences, and also to prevent VT after major orthopedic surgery, especially after knee and hip surgeries. And now the recommendations have emerged in treating and prevention of VT in malignancy. Especially when we talk about malignancy, there's an increased risk, especially in malignancies involving mucosal surfaces such as GI cancers and genitourinary malignancies. But from the trials, what they have found is there are 4 main randomized trials, and the meta-analysis had showed when compared to the low molecular heparin, which we used in the last, 4 or 5 years, drug is non-inferior to safety and efficacy, both provided there is a bit of high bleeding risk in the main cancers I have mentioned so far. With regard to DVT, in other scenarios, there are a lot of trials to back with strong evidence. So the actually guideline recommend drug over warfarin in managing DVT and pulmonary embolism. Okay, can we use drugs to prevent venous thromboembolism in acutely ill patients in our day-to-day setup? So it's still a bit gray area. So what they have found is from our usual practice of using low molecular weight heparin, if you use a drug, the efficacy is same, but there's a slight increase in bleeding risk. However, currently US has approved this rivaroxaban for this indication, but still in Sri Lanka, we are trying to stick to low molecular weight heparin for this particular indication. Okay. So how would you anticoagulate our Mrs. B? So I would, given her background of malignancy, I will still go for DOAC with the current recommendation. But what are the concerns? Her weight and the drug interaction, mainly the chemotherapeutic agents she will be on in the near future, are the main caveats in this case. So moving to the last case. So we have Mrs. C, a 46-year-old patient with coronary artery disease who is on dual antiplatelet therapy, was found to have atrial fibrillation. 2D echocardiogram doesn't show any valvular pathology. Weight is 55 and creatinine clearance is 50. So what is your choice of antithrombotic regime? Is it warfarin or DOAC? Or are you going to use dual antiplatelet or single antiplatelet? So basically it's a dual therapy or triple therapy. So using DOACs in patients with coronary artery disease. Currently, we use DOACs in coronary artery disease for basically 2 indications. One is if a patient with coronary artery disease comes with atrial fibrillation for stroke prevention, we have to anticoagulate. Other one is the low-dose rivaroxaban has been proven benefit in preventing major cardiovascular events in patients with coronary artery disease and peripheral vascular disease when combined with aspirin. That's the other indication. When we use DOAC in combination with antiplatelet, it's always a delicate balance between the atherothrombotic, cardioembolic, and the bleeding risk. So always we have to use validated tools such as Chadwick-score and Gray-score when assessing the risk. And proton pump inhibitors should be encouraged in all patients when we combining antiplatelet and anticoagulants to prevent the GI bleeding. So if when a patient on who is on drug comes to you with acute coronary syndrome, how do you proceed? So if a patient comes with ST elevation myocardial infarction, so being on anticoagulant is a relative contraindication for thrombolysis. So the preferable choice would be go for a primary PCI. So what you do is you stop NOAC and you can load with both antiplatelet and start additional anticoagulant with enoxaparin. And you can go ahead with the PCI. So if a patient comes with non-ST elevation myocardial infarction, the management depends on whether we are going for a PCI or not. If you are going for a PCI, you stop your NOAC and you give only one antiplatelet as the loading dose. The recommendation says we load with aspirin. And then we have to add on the enoxaparin also as per our usual regime, and you go ahead with the PCI. And if we are not going for a PCI, as in our Sri Lankan setup, what the recommendation is, we continue the dual therapy with NOAC and antiplatelet from the event onwards. There we don't have to stop the dual. So once we do the PCI and stenting, the patient has to be on triple therapy for at least for 1 week to prevent stent thrombosis. But depending on patient's thrombotic and the bleeding risk, we can extend that period up to 1 month. And beyond 1 month, there is not much evidence for the extended triple therapy. The bleeding risk of major bleeding risk is about 17 to 18%, which is a fairly high number. So what we do is we drop aspirin, we continue the dual therapy, and at the end of first year, we decide whether we go ahead with single therapy, that is only with the DUAC, or are we going to extend the dual therapy. That's basically depend on patient's thrombotic risk. Since 2013, there had been a lot of trials to choose what is the best antithrombotic regime for these particular patients, like Pioneer AF, the Augustus trial. What they have found is the best antithrombotic therapy combination is DOAC plus a P2Y12 inhibitor, preferably clopidogrel, with the minimum bleeding risk and without any increased risk of getting new thrombotic events. So what is the drug regime, antithrombotic drug regime you would choose from is a C. I would suggest we go for the dual therapy with DOAC plus clopidogrel, and I would consider proton pump inhibitors. The caveats in her case are her weight, which was less than the recommended weight, and the bleeding risk being on dual antiplatelet therapy, and her renal function, which is 50 milliliters per minute. So she will need reduced dose of DOAC. How do we decide the dose of DOAC? There are different dosage for different indications and different dose reduction criteria for each drugs. For an example, I will rush through you the rivaroxaban dose. So rivaroxaban, if we give for atrial fibrillation, the dose recommended standard dose is 20 milligram per day. And dose reduction is based on the creatine clearance. But if we take apixaban, the other available drug in our country, the standard dose is 5 milligram twice a day. And the dose reduction depends on patient's age, weight, and the creatinine clearance. So the reduced dose is 2.5 ppd. And if we choose to act to in DVT management, so we don't have to breach, what we do is for the initial weeks, we have to use increased dose. If rivaroxaban, we use 15 BD for 3 weeks, apixaban 10 milligram BD for 7 days. And for the maintenance, we have to use the standard doses. And when we use for the extended periods, for the long-term prevention of recurrence, we have to use reduced doses. For an example, if we are using rivaroxaban, we have to use the rivaroxaban 10 milligram daily dose. And if we use DOAC for VT prevention in post-orthopedic surgery, again, we have to go for the reduced dose. Rivaroxaban 10, apixaban 2.5 AD. And this is the another indication I discussed, the low dose rivaroxaban in preventing major events in coronary artery disease and the peripheral vascular disease. That the recommended dose is quite different. That is 2.5 milligram BD. Once we start the patient on the work, we have to do the education and follow up. We have to tell there's no need of closely monitoring with any coagulation studies, and rivaroxaban has to be taken with food. And since it will increase its bioavailability, if the patient is a strong patient on NG, we can crush the tablet and give. And we have to advise what to do in case of missed dose or accidental double dose. And the expected side effects, basically gum bleeding, heavy menstrual bleeding, and pregnancy cautions, we have to tell these things to the patient. In every follow-up visit has to be made a chance to reassess the thrombotic and the bleeding risk. Okay, drugs and bleeding. In the drugs and bleeding, risk of major bleeding is 2 to 4% per year. So this is a major challenge we will face. I will tell you why. So if a patient come with mild bleeding and major bleeding without any life-threatening features, we can do the supportive treatment. And as an adjuvant therapy, we can use tranexamic acid. But if comes with a life-threatening major bleed, we have to use reversal agents. So itacitinib is there for dabigatran and dexamethasone alpha is there for factor Xa inhibitors. The problem is, unfortunately, we don't have any of those two agents in our country. So the option we have is PCC, prothrombin complex concentrate, basically 4-factor PCC. That also it's very expensive. So this is going to be a major challenge when we are managing drugs-associated bleeding in the future. This is the last part of my talk today. So what would you do if a patient on drug comes with ischemic stroke? So incidence of ischemic stroke is around 1 to 2% per year in if patients treated with DOAC. So you know if patient has taken a DOAC within the last 24 hours, we can't thrombolize. Thrombectomy may be safe, but we have to think of reperfusion-related bleeding risk. And the problem is, the real question is, post-stroke period is the period where the patient has highest risk of bleeding as well as highest risk of thrombosis. So when are we going to restart DOAC? So a lot of guidelines, the European and the American guidelines still stick to the day 1, 3, 6, and 12 rule. That is to restart DOAC on those particular days for the TIA, mild, moderate, and major strokes respectively. If there's hemorrhagic transformation, it should be more than 2 weeks. But there are ongoing trials as well as trials like ELAN, which are investigating whether it's possible to restart DOAC earlier than this without increasing the bleeding risk. What about the ICH? If patient has certain ICH, can we reintroduce DOAC? So that has to be actually decided on case-by-case basis. If we are thinking of restarting, it has to be definitely after 1 or 2 months. So this is the last slide of the talk today. So if you happen to switch among anticoagulants, how would you do that? So it's very simple. So if patient is on warfarin, you check the INR. And if it is in therapeutic range, stop warfarin and repeat INR in 3 days' time. If INR is than 2, you can start DOAC, unless you have to wait till INR becomes less than 2. If you want to change other way around from DOAC to warfarin, you have to continue DOAC until we reach the therapeutic INR. So for the last 25 minutes, what I wanted to highlight is that with the appropriate indication, drugs are preferred to warfarin in managing, in preventing stroke and atrial fibrillation, and treatment and prevention of recurrent venous thromboembolism. And the other important fact is, being elderly and fall risk should not generally be a reason not to anticoagulate the patient. And lastly, drugs can be used in cancer-associated venous thromboembolism with the caution of bleeding risk. So these are my references. Basically, we have EHRA guideline 2021, very fascinating article. And I would like to thank Dr. Mrs. Yamuna Ranveer, consultant physician in NHSL, Dr. Iman Mujahid, consultant physician in NHSL, who are my beloved trainers, and Dr. Manu Chandra, senior lecturer, consultant hematologist, Faculty of Medicine, Colombo, and my family members and all the colleagues who helped to make this a success. Thank you.
Thank you very much. We have time for one. One aspect we don't have to do again testing, so that also costs some money. So what is your opinion on
Regarding the cost, sir, that's actually the brands available in Sri Lanka now, it ranges from 400 to 900. And 452, there's one brand, sir. And another one is there for about 800 rupees. So the problem is we had rivaroxaban, apixaban time to time in our government sector. 400, yeah, 450 per day.
Yeah.
Around 200, no, sir. Original and the generic brands. Original brands are pretty expensive, but generic brands are there for about 200 rupees. The problem is initially we had rivaroxaban and apixaban in our hospital also, but time to time it comes and goes. The problem, what I have seen is, so we start patients on rivaroxaban, so we discharge, and when the drug is not available in government setup, they stop it there. So that's the main problem we have faced so far. So currently, actually, we have stopped giving drugs unless patient is economically strong enough to afford it.
So I think gradually you even because it plays in the treatment of chronic coronary.
Yes, in chronic coronary syndrome, it's the low dose rivaroxaban can be used in acute coronary syndrome and chronic coronary syndrome both. So it is in combination with aspirin. So there the dose we use 2.5 milligram twice a day, and it has shown to reduce major cardiovascular events. The expense of bleeding, sir.